All right. So welcome everybody. I apologize for any background noise. I'm in the lobby of Renaissance Hotel in DC, just wrapping up our annual AUCD conference, which was very, very good this year. We actually had one of our former trainees, Jamie Jr. from last year, presented this morning as part of a panel discussion on transportation and accessible transit, which is really, really good. And just overall been a pretty, it's been their biggest conference to date. There's over 1,200 people here. So I encourage all of our current trainees in the future. This next year will be, I believe the conference is being moved to December. So I'm not sure if that'll make it more or less accessible for folks, but we'll see. So welcome tonight to Module 5 Zoom session on audiology. We have our 3 audiology leads with us tonight. We have Teresa Crumpton from Western Michigan University. Hi, Teresa. And Chelsea Conrad from Henry Ford Health Systems and affiliated with Wayne State, yes? Yes, okay, cool. And then Janie Handelsman, formerly of the University of Michigan, but now living the good life in lovely Petoskey, Michigan. I just have one piece. I was told that by at least one of our trainees that they didn't receive the evaluation from Friday's face-to-face session. Is there anyone else who didn't see that in their email? If you could go ahead and unmute and let me know. I want to make sure. Did anyone receive it?
This is Jessica. I didn't get an evaluation.
You didn't? Okay.
I didn't either.
Okay. Great. Thank you. Yeah, I'll make sure. Okay. I'll make sure. We'll double check and make sure that gets sent out, and the one for tonight as well. So, all right. Well, that's really all I have right now. I realize I'm sitting way too close to the camera, so I'll back off and mute, and I'll let you take it away.
All right. Thank you, Mike. Welcome to Audiology. I'm very excited to kick off this session. We are hoping that this will be meaningful to you. Hopefully you've had a chance to look at some of the references that were provided to you on Canvas. This session assumes that you have some knowledge, so we're going to start off with giving you some information, and then later on we'll be talking about some cases that you've prepared. All right, so the goals of this module are that you understand the importance of EDI, which stands for Early Hearing Detection and Intervention, and follow-up. I think that's one of our key things that we want you to take away from this. We also want you to appreciate the factors that can cause hearing loss. And we really want you to understand the practical issues that arise and factors that influence outcomes. And then finally, to understand the role of the team in management. And hopefully when we talk about the cases, you each will bring your own perspective to that. Next slide. So why do we care about universal newborn hearing screening? It's mandated now pretty much everywhere. The reason is that 1 out of every 1,000 otherwise healthy newborns and 2 to 4 out of every 100 NICU grads have permanent hearing loss. Hearing loss can be caused by genetic factors and environmental factors. And we know that hearing loss has negative impact on language development, social and emotional development, literacy and academic development, and ultimately vocational choices. We also know that when we diagnose hearing loss early and we intervene appropriately, the negative impacts of hearing loss are mitigated. It's also important to note that for a huge portion of the population, there is no known family history of hearing loss because it's recessive genetic component like connexin 26, which is one of the main causes of hearing loss in children. And this highlights the importance of screening and follow-up. So a lot of times when we first meet with families, we'll ask about family history of hearing loss, and they will say there is none. But what I want you to understand is that in many cases, they're unaware that there is actually a family history of hearing loss or a genetic cause of hearing loss. Next slide. So we know that permanent hearing loss occurs frequently. The updated Joint Committee recommendations were recently published, and you have a link on Canvas for you. The principles of EDI, so the early hearing detection and intervention, include screening the newborn, even if they're born at home, confirmation of hearing loss at no later than 3 months of age, and appropriate intervention by no later than 6 months of age. Interestingly, the recent guidelines that suggest that for programs that are really doing pretty well with the 136 guidelines, they're suggesting that you move to 123. So in other words, the same getting them back in for follow-up testing at 1 month of age, but diagnosing hearing loss by 2 months of age, and appropriately intervening by 3 months of age. It's important to note that we want the family involved in all decisions about communication choices, and all of the options for communication choices should be presented in an unbiased manner. We know that infants identified with hearing loss should have immediate access to high quality technology, meaning hearing aids and ultimately cochlear implants if that's appropriate. And it's important to have interdisciplinary programs that include professionals who really have expertise in dealing with children with hearing loss. So we don't want run-of-the-mill professionals being involved in this care. It's really important that all of the individuals who are included in care of kids with hearing loss have expertise in dealing with children with hearing loss. An additional important principle of EDI is that all children, even those who pass their newborn hearing screening, have monitoring happen. So the medical home is a really important part of the EDI system of care. And the new guidelines suggest that monitoring should occur as early as 2 months of age. So even at the 2-month well baby checkup, the primary care physician should be monitoring things. There are several components. Oh, next slide, please. Sorry. So there are several components to a successful EDI program. One is universal newborn hearing screening that we talked about. That's the first step, including, as I mentioned, infants born at home. The medical home or primary care physician plays an essential role, particularly in terms of ongoing surveillance, as I mentioned. It's important that audiologists oversee EDI programs and that diagnostic testing be performed by audiologists with expertise in working with infants and young children. Audiologists are not equally prepared to deal with little kiddos. Once hearing loss is diagnosed, enrollment in appropriate early intervention is key, and there are a number of programs that are available. Family support is so important since the family needs to be at the center of all decisions made about intervention, including modality of communication. I think that's really important. I think as audiologists, we may have some biases about what we would prefer because we know how good technology is, and yet we need to let the family be at the center of what we recommend and drive what happens ultimately. Also, we must be able to track babies. So part of EDI is an efficient and effective data tracking system. And ideally, we would like families of babies who are identified with hearing loss to be connected with other families who have been through this experience so that they can share their own experiences with the system and share success stories. There are a lot of success stories out there. One of the programs that's available is called Guide by Your Side, and there's more information about that on Canvas. Next slide. So there's really a lot of variability across the country in terms of this universal screening requirements. So in some states, for example, only cities of a certain size are required to have universal screening. Additionally, sometimes only hospitals of a certain size are required to have screening. We're fortunate in Michigan that all children are screened, and there is even efforts to include midwives in the screening. So we're doing pretty well in Michigan. There's also variability about the technologies that are employed. So there really are two primary technologies that we use for universal newborn hearing screening. One is called automated ABR testing, and the other is distortion product otoacoustic emissions. The new guidelines, actually, it used to be the case that follow-up testing had to occur with the same technology that was employed originally in the hospital. But the new guidelines say that even if the original screening is using automated ABR testing, follow-up can occur using distortion product otoacoustic emission testing, which makes it much easier to get these babies retested. It's important to note that the guidelines are periodically revised as evidenced by the new guidelines that were just published. So a successful EDI program, it requires a team of dedicated professionals who are all committed to meeting the 136 guidelines. Families should be at the center of all of the decisions that are made, and communication among the members of the team is critical to success. I want you to refer to the other information that is available to you on Canvas about this. And think about this as we talk about the cases that we're going to discuss. I mean, you all of your disciplines can play a role in this EDI team. Next. So ongoing surveillance is really important because it turns out that 5 of 1,000 children are estimated to have hearing loss in ages 3 to 17. Examples of potential causes of delayed onset hearing loss include head trauma, infection including bacterial meningitis, and certain genetic etiologies. So there are genetic etiologies that can have children have normal hearing at birth and can have progressive hearing loss. Some of those are syndromic, and also some infections are, like I mentioned, meningitis are important, and then as well as abnormal anatomic conditions, which you're going to hear more about when Chelsea talks to you. So again, it's important to note that there are some genetic conditions for which both parents have normal hearing. For example, connexin 26, which is a huge cause of hearing loss in children. So now I'm going to turn it over to Chelsea, who's going to talk to you about some conditions and some other factors.
All right, very good. So one of the, or two, I guess, of the main points that we really want you to understand when you leave tonight's call is how children with other developmental disabilities and hearing loss, what issues might present for those kids. And then as Janie was just mentioning about delayed onset hearing loss, so kiddos that may have passed their newborn hearing screening but develop hearing loss somewhere later in hearing, or later in early childhood. One very hot topic in the hearing world and epidemiologic world right now is an infection called congenital cytomegalovirus. So we'll talk a little bit about both of these points. Next slide, please, Mike. All right, so just talking about in general, children with developmental disabilities and hearing loss, they are commonly seen together. So somewhere between 25 and 40%, depending on who you ask, of children with permanent hearing loss are going to have some additional developmental disability. As Janie mentioned, sometimes those are syndromic. So about half of all hearing loss etiologies have some type of genetic component, with 40% of those genetic losses being associated with some type of syndrome. So of course, they're going to have additional challenges that we need to address and strategize regarding. The other, I would say, very common issue we see in the clinic would be autism. So these two are often seen together within the same patient, or sometimes audiology is really just helping to provide information about hearing status in children with suspected autism. So this is something that certainly complicates how we test these children, diagnose these children, and really what we can do in terms of intervention. Children may have vanilla hearing loss, or they may have other stuff. And that other stuff can be, developmental issues. It can also be physical issues. So some syndromes are associated with craniofacial abnormalities, where we might be more concerned about middle ear stuff. So conductive hearing loss, more so than that inner ear hearing loss. So just things that we're keeping in mind and looking out for. And something that you may want to look out for. So you may be working with children that have developmental disabilities and may also have hearing loss, which sometimes is undiagnosed and might be something you're in a position to recognize and recommend evaluation. Next slide, please, Mike. Congenital cytomegalovirus, CMV. I'd be curious if any of you have actually heard of this. Most people have not, but it is a very common cause of hearing loss. So about 20% of all hearing losses that are otherwise unknown etiology are suspected to be due to CMV. And this is a very dangerous disease in that it is nearly unknown. Most women of childbearing age have never heard of CMV, and that's what's dangerous about it. So if you are infected with CMV during your first or second trimester, you can potentially have some very deadly outcomes, including death. Some of these babies will not survive. The issue is not only have women not heard of it, but they may be asymptomatic, or if they are infected, they may just seem like they have a common cold. So it's really difficult to know about CMV. And if you are infected particularly early in your pregnancy, and particularly if it's your first exposure to CMV, you can, your infant can have very serious consequences, including some serious anatomical abnormalities. In addition, these children are at risk of developmental disability and hearing loss. Just like moms may be asymptomatic when infected, so may babies. So only 10% of babies that are exposed to CMV in utero are actually going to be symptomatic at birth. Of those, about 10% or 10% of all those infants are going to have permanent hearing loss of some kind. Additionally, another 15% are going to develop hearing loss later. So that makes it a bit challenging to monitor these children if we don't necessarily know that they were exposed to CMV. The reason we're bringing this to your attention is there's a lot of attention being drawn to CMV really around the nation, but specifically right here in Michigan, there's actually a bill pending in the House, hopefully to improve funding to help educate women of childbearing age about what CMV is, what to look for, and hopefully in our lifetime we will see universal CMV screening, which would help us monitor these children better. Next slide, please, Mike. All right, so why do we care about this? Why does the MyLend have an additional audiology supplement? Why is hearing so important? When we talk about hearing, we talk about ears, we talk about sound, but really we are talking about brain development. And as Janie mentioned, there are absolutely other modalities of acquiring language, American Sign Language being one. It is a completely independent and whole language, but most babies, 90% of children with hearing loss, are born to hearing families. And just like you might speak English and choose to teach your child English, most children with hearing loss are born to families that want their child to speak and hear. And infants, even before they're born, from 27 weeks gestation, are really pre-programmed to learn language. And we do all of this simply by overhearing. Just being exposed to language is really how we acquire it. I'm sure you do not remember your parents sitting you down and saying, "The dog ran up the hill." Okay, the is a word, dog is a word. Here's what the means, here's what dog means. No, we don't do that. You simply hear language, and after repeated exposure over and over and over again, you learn what these concepts mean. Can you hit the next slide, please? Thank you. Okay, and it takes a lot of overhearing, a lot of incidental learning for us to be able to do that. So I think this is phenomenal. The average child is going to be exposed to 46 million words by their 4th birthday, which is just incredible. We are listening, listening, listening. That's how we learn to talk and understand. It's also how we learn to read. So if you hear for about 20,000 hours, you're going to be well on your way to developing some literacy skills. I do like to highlight that this is very different for children that come from lower SES backgrounds. So there's a project known as the 30 Million Word Project. Children from the lowest SES backgrounds are actually going to be exposed to 30 million words less, so 16 million words by age 4. And I'm certain you can see how that would have some downstream effects on language capabilities as well as literacy skills. Those lower SES kids, just like our kids with hearing loss, they're at a disadvantage. Children with hearing loss cannot access language to that incidental, casual overhearing like normal children do unless they have technology on. And furthermore, even when we have technology on, kids with hearing loss oftentimes need repeated exposure to be able to acquire the same mastery of language, words, and concepts. So on the left-hand side of the screen here, you're looking at just a quick graph that I've made of what it's like for a normal hearing child versus a child with technology. It's hard to get hearing aids on cochlear implants on a toddler all day, every day. It's consistently something that parents have a difficult time with. If you imagine a normal hearing toddler, they have an ear that's always open. So even when they're sleeping, they're still able to process information. A child that needs hearing technology, it's only delivering information when their technology's on. So if you have a child that wears their hearing aids 4 hours a day on average, Mike, if you'll hit the next slide, please. It would take them 6 years to achieve the same amount of listening time to a child that wears their devices 10 to 12 hours a day. So not only do we need to get these kids technology, but we need to have it on and consistently delivering sound, again, to work on that auditory brain development. Next slide. Okay, so again, the goal here, we want children's brains to learn new concepts and to understand sound and its meaning. And we do that through use of hearing aids or cochlear implants. There's also, and these are things you might see in your practice, sometimes parents will bring them to therapy sessions or educational environments, assistive technology. So think of this like a speaker and a microphone, where the microphone is being used by the person talking. But instead of the speaker, you're actually using the hearing aid or the cochlear implant to deliver sound directly to that child's ear. So again, we need to not just have the technology, but it needs to be on the child's head and working. So we have a tool called data logging. So these devices collect statistics about how they're used. But this is something that every care team member, anybody who's working with a child with hearing loss, can really have an influence on. So my favorite is when mom walks in and you see this is Phonak, this is a hearing brand. The hearing aid case is in her purse, right? So I will stop everything before I proceed with my appointment and say, let's get your child's ears on, right? Because they're not going to be able to participate in their care or their therapy as well if they're not able to access information, just like they would need that same technology in your sessions. Next slide. Okay, a hearing aid. I'm certain many of you have seen these. In general, you're going to have some type of portion that goes behind the ear. It has a microphone. It picks up sound, and then an ear mold, some type of piece that's going to deliver sound down through the ear canal through the normal auditory system. They come in all different sorts of shapes and sizes. There are other hearing aids, I should mention, but in general, this is what you're going to see on the pediatric population. You can get glitter, you can get wild colors, you can go for something inconspicuous, depending on the age of the child. And then next slide. You may or may not have seen a cochlear implant. This is similarly, typically on the child, you're going to have some portion behind the ear, but instead of going through the ear canal and delivering sound through the eardrum and that normal mechanism, we actually deliver sound through a radio frequency to the internal receiver stimulator. This is a surgically implanted device that is going to deliver electric sound directly to the hearing nerve. In general, you can think of this that children with less hearing loss are going to use hearing aids. Children with more hearing loss are going to use cochlear implants. Next slide. It's important to recognize that simply putting on technology does not restore normal function. So depending on many, many factors for that particular kiddo, there's going to be various I think amount of benefit and various degree of mastery in terms of how do they use and understand sound. So just because a child has a hearing aid or cochlear implant on, they're not going to hear normally. Children that are ID'd late or have poor intervention services are not going to be able to utilize sound as well. Of course, we know socioeconomic factors are a barrier in many things, including hearing loss and technology success. Obviously, children with other developmental disabilities are going to have additional, again, strengths and needs. Some children simply do not have normal internal anatomy, so even with technology, we're not able to restore enough sound, and that might be a time where we're looking at adding a visual or other type of communication augment. Obviously, children with more hearing loss have more barriers to overcome. Children are going to be using different types of languages, maybe multiple languages, maybe multiple modalities, visual and auditory. Some people are just going to use their devices to be able to be aware of how loud they're speaking. So it might be that I put a hearing aid on to control the volume of my own voice and not so much to be able to understand other individuals. So how you hear and how you use your technology is tremendously variable. Next slide. There's also a lot of variability in the type of environment in which we communicate. So Mike gave us the perfect example. He's sitting in a very noisy hotel lobby, so we hear a bunch of this background noise. It doesn't mean we can't hear him, but it does mean that we are using a little bit more cognitive load to be able to understand him. Or I think I heard someone mention going to the local pub and potentially ordering a beverage. Imagine doing that when there's noisy music, right? That's much more difficult to do than if you're sitting at a quiet restaurant with just a single waitress. So I've kind of created a visual analog here. So on that top bar, it says, how are you doing today? But it's really hidden by the background noise, right? The visual competition is making it difficult there. If we add hearing technology, it makes it stand out a little bit more, but there's no substitute for silence. So if you can limit background noise, it really makes it much easier for the listener to understand what's being said. In addition, distance is a huge factor. So if you get beyond about 8 to 10 feet of somebody who's using hearing technology, it doesn't work as well. It's not that they can't hear, but it loses a lot of the sound fidelity that it has when you're closer. The speaker matters. If you are talking to your mom, a very familiar voice, versus a telemarketer that you've never heard before, you're going to have differing levels of understanding, even with normal hearing. Rate is a huge one. It seems very awkward to speak slowly, but it has a tremendous impact on helping individuals with hearing loss understand what's being said. And then finally, providing individuals with context. So if we're talking about my birthday party, your top-down processing is going to help you know that I said cake and not lake. So it's these are types of factors that when you're providing therapy or if you're in the educational environment, these are some factors that we do have some control over. Getting closer to whoever we're talking to, slowing down, providing, a topic before we dive into new information, and then as much as we can, limiting background noise exposure. And then next slide. That's incredibly important. I want you to think about a child sitting in a classroom trying to learn the word constitution. If I'm stuck on this first level of what did she say, I have no chance of learning what does that mean. So giving children sound in a clear and consistent manner is going to make it easier for their brain to focus on what does it mean rather than what did they say. All right, next slide. These are not your grandparents' hearing aids, which is really, it's great. I think from a parent perspective, there are a lot of tools. You can track apps. Is the device on and working? What's the battery status? How long has my child been using it? For older kids, I want to stream my iPhone through my hearing aids. Those are things that kids want to do the same thing that their peers are doing, and now technology is giving them that. Next slide. Rechargeable batteries, I think, have been life-changing. So hopefully you don't have families coming into your appointments with the old throwaway type batteries. They may still be out there, they may still exist, but it's helpful for families to not have to worry about purchasing batteries or to worry about changing a battery in the middle of an appointment. Things are made to be pediatric friendly. So for little kiddos, there's indicator lights on their hearing aids or their cochlear implants, which will give their parent or healthcare team information about whether the device is on or working. If you're ever in a really rough situation and want to do some basic troubleshooting on a hearing aid, if you cup it in your hand like this, it should go ee, which would be a sign that it's on and working. And if it's not, of course, we need to check the battery or check and make sure it's clean, those types of things. Next slide, please. Okay. So when a child walks into a visit or a meeting with you in any respect, if they have hearing loss, the first step is always, does the child have their hearing aids or cochlear implants on? If they don't, everything should stop until we get that child in a position where they can participate in the meeting. Of course, that means, again, making sure we've got a charged battery. It means making sure the device is clean and delivering sound. How do you check those types of things? Never, never, never ask them, can you hear me? The answer to that question is always yes, even when they didn't. So asking them something like, with your mouth or your hand over your mouth, what did you have for breakfast today? Or say the color purple, right? Ask them to do something where they don't have context to make sure that they're understanding. And then involving children in this process. So getting them to understand, this is how my hearing aid works. This is how I change a battery. This is how I put it on. We believe it's never too early to start that process of getting kids to be in the driver's seat regarding their own future, I guess. All right, next slide, please. Retention is a challenge. Keeping these on your heads, if you can imagine, toddlers, busy kids, it's hard to keep them on. So one of the barriers that parents often tell us about is I have a challenge keeping this on my kid's head. Babies that get a cochlear implant on their first birthday, in those first few months following activation, their device falls off on average 150 times a day. So it's a lot on parents of asking them, put it back on, put it back on, put it back on. And there's not alone. So Etsy, I think, has been huge in terms of there's all sorts of headbands and hats, and this top stick is actually toupee tape. It's double stick tape that's made for men's false hair, but you get the idea. It's devices to help keep these in place on children, so they can again focus on what does that mean and not what did they say. Next slide. And then finally, if you have questions or you get into a situation where you have someone in your office and you're thinking, gosh, how do I do this? Modern technology is accessible through our Google, YouTube. There are beautiful videos on just about everything. How do you put a hearing aid on? How do you change a battery? And they're oftentimes captioned, which is great for older kids. If they're holding their hearing aid in their hand, of course, they might not be able to hear a video so well. I wonder, there's a couple questions here. I'm wondering if I should answer those quickly before we just transition to the next kind of section. So Jessica asked if hearing technology is typically covered by insurance. So private insurance, maybe. In the state of Michigan, hearing loss qualifies that child for Children's Special Healthcare Services, which absolutely does. So they may not have it through their Blue Cross or Humana policy, but they definitely can get it through Children's Special Healthcare Services. Bree asked, with early intervention, do kids with aided hearing develop better ability over time to filter out background noise? Wondering if the brain over time develops the ability to accommodate. The answer to this is yes and no. Some children that are fit early and fit well, get good access to early intervention, do phenomenally in background noise. Some children with very similar variables do not. So it's hard to predict. I would say there are some kids that do incredible with their hearing technology, and some kids it remains challenging. So it's hard to answer that question in a straightforward way. And then Kristen asked about autism and hearing loss correlation. Is there an underlying genetic syndrome? I don't believe that is established in the literature at this point, or that there's a great understanding of the relationship between the two. And Janie or Teresa, if you have anything to add, please jump in.
Am I muted or not muted? Mike, can you hear me?
Yep, we can hear you.
Yep.
All right. I know that there is a strong relationship between autism and hearing loss. There are lots of resources out there that are available. I did a 2-hour video thing for the American Speech and Hearing Association, just with one of my speech pathology colleagues, talking about the relationship between hearing loss and autism. So kids with hearing loss are more likely to have autism than their typically developing peers, and similarly, kids with autism are more likely to have hearing loss than are kids without autism. So we know that relationship exists. We don't know the underlying etiology necessarily.
All right, I think next slide, and then I will pass it over to Teresa here. Teresa, I think you're still muted. Oh, there you are.
I wasn't sure you were going to say anything on this slide. So what we want to do is talk for about 5 minutes about cases. The cases aren't on the slide, right, Janie? No. Okay.
No.
Okay. So can you hear me okay?
Teresa, just a second. First, talk about when to refer to audiology.
Oh,
and
okay.
then that case
Okay. So as you can see, the bottom line says it all. So if you have a concern for hearing, refer, and it's important to refer to a pediatric audiologist. So whenever there are concerns for speech and language development, whenever development is lagging behind, or if you have a child in your classroom and they're not progressing academically, or if they don't seem to hear well in that classroom, when in doubt, refer. Because remember, newborn hearing screening is one step, but remember the prevalence of hearing loss increases between early childhood and school age, so it's really important. Next slide. Okay, so here we go. We have a case that was important to me because we are doing a great job of screening for hearing loss, but one of the areas that we want to continue to work on is having parents keep the appointment after they have failed a newborn hearing screening. So that is why we did case number 1. So this is a 1-month-old that's being seen today for a well baby check. He was born full term and healthy, but he didn't pass the hearing screening. And he did not show for his audiology appointment. And that is common. Almost half of the children that failed newborn hearing do not keep their appointments for the follow-up. So we asked if you could kind of think about some of the issues regarding follow-up and from your own perspective, and to talk a little bit about what conversations you might have with someone who is seen in your practice that didn't show for their appointment, and why early diagnosis is so important. And then what's the impact? What's the impact of hearing loss? And then what's the impact of untreated hearing loss? So as a group, I wondered if there are some some comments that you came up with, or some conversation that you might want to have about these issues.
So do you want to call on like group one to
I
follow
can.
up?
Okay, so I know in group one we have speech pathology, audiology, social work, ABA therapists. How would you respond to a family that maybe came into your practice and you asked if they've if they had a newborn hearing screening and they did not show for their follow-up? What kinds of conversations might you have? And how about Alex? Maybe you can help us understand a little bit.
So we talked about how it would be important to talk about speech and language development with these kinds of patients who have a hard time keeping their appointment or coming back for an appointment. Let me read what else we had here. Talking about the importance of early on with the family and how they can help and make a referral for different services they may need. And just later outcomes associated with this early identification and how the importance of treating it early to get better results later on.
Right, so helping them to see what the advantages of the diagnosis.
Mm-hmm.
Yeah. And did you guys talk a little bit about what some of the challenges might be that parents might face for keeping a follow-up appointment?
I think a big one, if this is what you mean, is like transportation is a big problem for a lot of patients. And so helping them arrange or find services that offer transportation.
Mm-hmm. Right. And then one of the barriers that I often encounter is that parents often feel like their baby responds to sound. So they don't necessarily have a strong belief that that is a problem. So letting families know, I think, that there can be varying degrees of hearing loss, because that's one of the number one reasons that parents don't come back, because they believe that their baby hears. So what kinds of testing, and I put it out to the whole group, do you think this child would need? If that you were, what would be your next steps for a family if they were in your office or hopefully in the pediatrician's office? How might you facilitate the next steps for this family? Anybody?
Does someone from group two want to respond to that?
So one of the things I think is important is helping families know where to go. I think that it's really important to help families to identify the practice and maybe help them make that next appointment and following up back with them if you see them again. How about anyone from group 3? Any other comments about newborn hearing screening or follow-up of newborn hearing screening? Are there any questions that you guys might want to have about newborn hearing screening in terms of follow-up? I think Sarah had
So Lisa Huckberry has a comment she wants to make after the trainees are done with their comments.
Okay. And I think, Sarah, did you have a question? I saw a question came up, but I can't see what it is. No? Okay.
I didn't have a question personally, no.
Oh, okay. All right, good. All right, so let's go maybe next slide, next case.
Lisa, before we move on, did you want to comment?
I do, thank you. Can everyone hear me okay?
Yes.
Yep.
Oh, sorry, a plane is going by and it's really loud. So I just wanted to add, because my daughter has hearing loss. She's 15 now. but she was also born with Down syndrome. When she was born, she had developed eye drops, so I was hospitalized. They induced early. She had multiple very, very critical health issues when she was born. So she was in the NICU for almost 7 weeks, and I knew they had tested her hearing in the beginning, and then in the end, I guess they did again, and on the left side, I believe it was, she had failed. So we had, in addition, she was born with a congenital heart defect that had to be repaired. So she had numerous medical issues when I took her home. And I don't think in my mind, I don't know that I actually forgot about that, but like I said, it was really crazy for the first year or so.
Right.
But I didn't know that really meant that she did have hearing loss. She did seem to be hearing, and she was seeing pediatrician. We were involved in early on right away. Nobody brought it up to me. And it wasn't until I got, I'm assuming, a letter from newborn screening or the state or Eddie or somebody about I needed to follow up with a pediatric ENT in audiology to have her hearing checked. So I didn't take her in until she was 2 years old.
Yeah.
And I'm a pretty educated woman, and I could have taken her in so much earlier had I realized. So I just want to, and then I was in quite a bit of a shock when I realized she did have moderate hearing loss in one ear and mild to moderate in the other ear. So I just wanted to share my situation because, hopefully it's better. That was 15 years ago, but had I not got that letter in the mail about I needed to follow up, I don't know at what point I would have, since for pediatrician and nobody else brought that to my attention.
Right.
And it just through the cracks with heart surgery and numerous hospitalizations, et cetera. So I wonder now, like, what are the statistics on babies who spend a long time in the NICU, or any time in the NICU, but also leave and have multiple other conditions, and how that gets flipped. So just another situation I wanted to bring up.
Right. And I think you brought up a good point, is that your daughter had multiple health problems and you're just trying to manage all of those. But it also shows how important the team is, because if you are involved in early on asking that question, did your baby pass newborn hearing screening, and were you able to go to the follow-up appointment? We all are part of that team that can ask that question. And I would encourage you all to put that on a case history or consider that when you're doing an intake, because we really need to be monitoring for late onset hearing loss, or for those who weren't able to keep their appointment. That's great. I'm glad you said that.
So you all had the background that Ellie is a 3-year-old child who's not talking. She's otherwise healthy. She presents to your clinic. What information would you like to have about her history? What referrals would you consider from your professional perspective? And what are your initial concerns about why she is not talking? And I'm going to call on group 3 to present your initial concerns or answers to those questions.
Hi, I'm from group 3. So first of all, we would want like a comprehensive health history, probably a review of systems to see what's going on first. We have a list of questions that we wrote down, like, has she had a full hearing evaluation? Like Lisa said, has she spent some time in the NICU? Was she full term? Are there any other developmental delays? And then as soon as you get into the room, you can always start with, talking to her and seeing if she follows any cues, such as whenever you say her name, does she respond, or can she follow simple instructions, anything like that. Any craniofacial anomalies, whether or not she scored, or what she scored on her MCHAT, and things like that. We can also delve into her family history. So just a lot of information is definitely missing. And so a full workup would probably be necessary in order to do anything.
Okay, good. Yeah. Does any other group have anything more to add to that? Otherwise, we'll move on to giving you more information about this case. So next slide. All right, so here's more additional information about case 2. So the parents have been struggling to have adequate housing, and the primary care physician has been changing due to their Medicaid coverage. Mom was using alcohol and marijuana throughout her pregnancy, although she's now sober. Dad is in and out of work and is not always present with the family. So we got a lot of social issues here. Ellie has 2 older siblings, each with different fathers who like to talk for her. Mom has some family supports through her siblings and mother. Mom has been concerned about Ellie since her speech is lagging behind her siblings. So here's the question I want you to think about, and we're going to break you into your virtual spaces. So how does this additional information impact what you would recommend in terms of referrals and or suspicions about why Ellie is not talking? And I think we're going to give you, let's see what time it is. We'll give you 5 minutes, 7 minutes. 7 minutes to talk about this, and then we're going to have you report back out. So, Mike, can you put everybody in virtual rooms?
Sure. So same procedure as before. I will now send you all out, and I'll give you a 1-minute warning before we come back. Okay.
All right. So I'd be interested in hearing from group 2 about their sort of main things that they talked about this case, given the information they have. So specifically, you know, what more would you want to know, and what referrals are you thinking are appropriate given the information you have?
We did talk about social work getting involved and kind of meeting with the family and talking with the family and seeing if there are any resources that we could help them out with, or you know, any type of therapy interventions or anything of that sort. I also mentioned asking the family how they communicate with her, or how she communicates with others at daycare or school or her grandparents, and seeing if maybe there is some type of temporary kind of workaround that we could do until she gets her all of her assessments completed with the audiologist and SLP, and maybe an autism screening. We talked about. Does anybody else have anything to add?
I think one thing we were saying is that speech and ABA were kind of on hold until they would get the hearing results. But we can still, the SLP was mentioning they can still do an autism evaluation, even though she's not conversing, but finding a way for her to figure out how she's communicating with the family in the meantime while all the other follow-up appointments occur was very important.
Good. All right, could you go to the next slide, Mike? So here's your final information. So this patient was referred to pediatric audiology. Behavioral testing could not rule out hearing loss because she was not able to participate fully in the testing, which required us to do a sedated auditory brainstem response testing and distortion product OAE testing, which revealed responses at normal levels, ruling out hearing loss as the cause of her delayed language. So the next question is, what will you consider to be next steps? What professionals should be involved in determining why Ellie is not talking? And what supports are she and her family likely to need moving forward? And I think given the time, I'd be interested in just hearing your thoughts about this as opposed to breaking you out into separate rooms. If any of you have any ideas about this, because I want to get to the third case. And I would just comment that this is a very typical situation. We have children coming to the audiology clinic on a routine basis who are 2 years old or 2.5 years old, who are not talking. In some cases, parents have had concerns about hearing for a while. They may have talked to their primary care physician about it, who sort of said, no worries, they'll grow out of it. And then we see them, and our job is to figure out whether there's hearing loss or whether there's not hearing loss. But sometimes, having been the person in the operating room who has delivered the normal hearing diagnosis to parents, sometimes they are very upset and would really rather have their child have hearing loss than to have to consider autism as a diagnosis. So I think we brought this case forward to you because this is really common. And I think for all of you to be aware that, one, hearing is a really important thing to rule out at the beginning, but also, when parents have concerns about speech and language development and about hearing, I think it's incumbent on all of us to make a referral to audiology and then rule that out and then move forward. So I'd be interested in any other comments that you guys have. And now that it's not hearing loss, so what supports do you think Ellie and her family need moving forward?
She's too old for early on, so I would say refer the family to their local school for assessments there. Also, maybe to a developmental behavioral pediatrician for an assessment. And then also maybe perhaps social work still to see if maybe it's more of a social anxiety situation or something of that nature.
And what I'm still wondering as well is, has the family ever heard her make a vocalization of any kind, or is she has she ever said a word, or is she just not talking at the same level as her same age peers? And sorry if I missed the answer to that earlier.
No, they didn't give you a lot of answers.
Okay. Because if it's the no vocalizations at all one, there would probably be a different referral than vocalizations but no words versus some words but no sentences, etc.
Right. And what do you think about the social situation? I mean, are there supports that the family would need given the social history? And how might you approach that as in your own specialty? Like if you had this child coming into your office with this situation, are there things that you might consider proposing to the family that could be supportive?
This is Kristen. From the social work perspective, one of the things that we talked about in group one was, since she's 3, it seemed like the family maybe is lower SES, and could she get into a good preschool program, like a Head Start or something that would expose her to more language, and might that that would probably be good for lots of reasons, not just the language development, but certainly that could help.
Good. Any other last comments? I want to turn the last case over to Chelsea, but I don't want to miss any important comments from you about this case. We just have a few minutes left, so.
Might be a good infant mental health referral to just to have somebody, kind of going to the house and doing some modeling if, mom's still recovering, and just another person to kind of help with skill set maybe.
That's a good comment. Thank you.
I agree.
Anything else? Okay, Chelsea, next slide. And Chelsea, do you want to
Yep,
take over?
absolutely. I want to make sure I'm back. I had a mic issue a moment ago. Am I okay?
Yep.
Okay, perfect. So you may have caught a trend here. So we're trying to give you all, these are very common situations. Baby that doesn't follow up, or a 2-3-year-old that's not talking. Here's a 7-year-old where we have diagnosis of hearing loss, though he did pass on his newborn screen. So he ultimately had a pediatrician screening, referred on that, came for diagnostic testing, and then was diagnosed with hearing loss at 2.5. We don't know what caused his hearing loss, and we have not been able to do genetic testing. He uses his hearing aids, no issue, and he has a lot of accommodations in his educational environment, including a personal FM system. What do you think? We'll split into groups here. Is there anything else you would want to know about his background, about what's happening at home, his current speech and language level, anything else that you think would be relevant? So if we want to, in a moment, hold on, let me present the additional information here. Or sorry, Janie?
No, I was just going to say, they should have already dealt with that first stuff.
Perfect. Okay.
And we talked about that, but this is the part.
So we'll add on the additional information here. So we know all of that stuff about him. You guys have considered what you might want to know. So now Henry's a disaster in the classroom. So he's otherwise been really compliant, no issues, and now he's distracted and disruptive. The teacher has called home. So here's the things that we want you to discuss. It would be, what do we need to do regarding Henry? How do we want to talk to him about this? Are there any additional educational accommodations we should consider? In addition to, do the hearing aids work? What do we need to figure out could also be going on? And if you have a child, not just Henry, that is in your clinic or classroom or wherever, how do you talk with them if they're inattentive or distracted? All right, Mike, if you want to split us out, and then let's say 5 minutes.
Okay, it sounds good. I just said something in the chat here.
Oh yes, snap a quick photo of the screen.
Snap a quick photo of the screen if you want to have this with you in the room. 5, 4, 3, 2, 1. All right.
Chelsea, you want to take over the discussion of this?
Yes, absolutely. Rather than call on a specific group, I wonder, is there someone that's willing to give us kind of a summary? Let's talk about first about what you would want to rule out in terms of what could be going on, what could have caused the change in Henry.
I can start. Our group kind of had we're asking, is it a new behavior? How's his health overall? Is he in a new classroom that's kind of changed on him? We also wanted to know when was his last hearing aid check appointment and most recent hearing test. Just because he had no complaints, I think the history said he's wearing that without complaints doesn't mean the hearing hasn't really progressed, especially since we never got genetic testing on him.
Great. Did anybody have any information about educational accommodations or ideas they have about what we could be doing in the classroom to help him?
Our group also talked about finding out more information about his academic skills. So are his skills higher than the instructional level that's happening in the classroom, and maybe he's bored and kind of checking out, or is he missing skills and therefore, so you're seeing more behaviors during certain types of tasks. Also looking at like his adaptive skills, so his ability to kind of communicate his needs if he's struggling or needing help, and kind of finding out more information about his academic skills.
That's great. Anyone else? Maybe let's talk about, what would you say to Henry? What would we talk to him about? How about someone from group 1?
Our group talked about asking Henry if is he still able to hear his teacher? Wondering if either something's gone wrong with the FM system or his hearing aids, perhaps. A technological problem.
Mm-hmm. Yeah.
And I know in our group, someone mentioned whether or not he's able to hear his friends. Is he having trouble socially? So I thought that was a really good point.
Yeah, that's excellent, especially at his age. There might be a transition happening in terms of what he wants from his hearing of academics versus that social information. Yeah, absolutely. We had an interesting discussion in group one about other types of techniques for children with that are distracted or inattentive. Natalie, can I pick on you to share some of your information, please?
Okay. Yes. In occupational therapy, I was saying I daily work with kids that are distracted and unable to focus due to myriad issues, but often we engage the child in a gross motor activity, proprioceptive activity, joint compressions, something to kind of calm their sensory system and allow them to focus on a non-preferred or preferred task. So we do that on a daily basis. And if Henry possibly has some sensory integration issues, or he's sensitive to some obviously sound, possibly maybe he's not seated in the right area in the room, we were discussing that, there may be a noise that's agitating him, or just excessive energy, not enough gross motor proprioceptive input output. So there are some things you can do in the classroom and accommodations you can make to allow the child to have what he needs on a sensory basis.
Thank you for sharing. It looks like we just have about 5 minutes left. So if anyone has, I think we can open it up. If anyone has any comments or questions at this point.
Mike, do you want to go to the next slide? It's just yeah, I mean, I think personally, you guys have done a great job in responding to the cases. I hope that this has been useful for you. And I would welcome you to ask us any questions in the last few minutes that we have, or comments or whatever.
I observed an audiology clinic yesterday as part of the Lund experience. And so it's kind of timely because I learned a lot, but I was so surprised they had a 2-year-old come in with no verbal language, and they were trying to rule out audiology or a hearing issue. But how much effort went into getting this 2-year-old to engage with all these reinforcer systems. And I was very surprised at how much goes into getting those assessments with the little one.
Yes, it's creativity.
And I always say I'm not above bribery, so I will talk to parents about favorite games and stickers, and when kids do a good job, I'm not ashamed. I will tell parents they need to do ice cream because it's a lot of work. Hearing tests are boring.
Any other comments or questions for us?
Just as on the opposite end, I still am struggling to understand what happened at my own daughter's audiology. I think it was, I'm not even sure if the person was an audiologist. I know she went to an ENT and then had some kind of hearing test. It was the one, I can't think of the technical name, but where there's a sound and then like a light up toy is shown, and she couldn't localize any of the sounds. And I mentioned in the chat that yesterday she got tubes put in. So if any of the audiologists have in the group can have any ideas of what I'm supposed to do now. I know this is my own personal life and everything, but the only thing I know is that we're supposed to follow up with the ENT in 2 weeks, and I don't even really know if my daughter has hearing loss or what type it is. So yeah, for explaining all of the information to parents is very important.
Right.
It sounds like you didn't get great information
Right.
from the audiologist, which is unfortunate. And I think we would recommend that her hearing be evaluated following the tubes. I'm sorry that you didn't get more information from the audiologist. Teresa, do you have something else to say?
Well, I think that sometimes in a medical ENT practice, their focus is on resolving the medical condition and isn't always as in-depth as what it should be in terms of ruling out hearing loss and making sure it's adequate for speech and language development. So I'm sorry too that you had that experience, and I would encourage you to seek out a pediatric audiologist who can really spend the time and get the evaluation done. Yeah, yeah. And is she hearing better after the tubes? Can you notice a difference?
It's hard to tell, yeah, because I think she could hear before, just not necessarily. I don't know how much, and I don't know how fast it necessarily recovers either. But I'm just hoping now that the fluid's gone that things will improve.
Right. Sometimes parents say they notice a difference right off the bat, and sometimes not, because the hearing loss related to fluid can be so variable. So, yeah.
Thank you.
So Lisa has something to add, and then we're close to our time. So Lisa?
Yeah, I just wanted to say in regards to Steve, so like when my daughter, when I had to take her back for the follow-up test, I don't even know that they tested her then, but they determined she probably needed tubes. And so when they did her tubes, they did an ABR, auditory brainstem response, I believe is what it's called, while she was under for the tubes. And that's where they diagnosed her with hearing loss. But they came right out and told me after she had the tubes placed. And when they did that, the audiologist actually came out and told me. And we were at Children's Hospital of Michigan. Now we go to Mott now, but that was our experience. So I guess I'm surprised if they had her under that they also didn't do an ABR just to test.
Yeah, not every place can do those. So I think that's the part of the importance of trying to find places that have pediatric audiologists and can do a full service of pediatric
Absolutely.
audiology. So, well, thank you. Well, you guys have been great. I really appreciate how you have interacted with us tonight, and I hope that you'll look at the resources that are on the site, and that you will contact us directly if you have any questions or concerns. I think this has been one of the most interactive audiology sessions that we've had, so I really appreciate everyone's involvement. I don't know, Chelsea or Teresa, do you have anything else to add?
No, I thought it was great. Thank you for your input. It gets tiring at night, and I do appreciate the conversation.
Yeah, thanks everyone.
Yeah, thank you. Thanks, Janie, Teresa, and Chelsea. And I hope that the evaluation will get to you tonight. I went back out. You didn't get the one from last Friday, so we'll make sure those get out. So.